Thank you, Prof. John, for enlightening us about mimosa and just telling more people about it. I read about mimosa a couple of years ago and I was so impressed by it. And I actually told some of my friends and dentists about it and they were so impressed by it. And hopefully that can scale up to the future in government healthcare. So, introducing the third speaker, Associate Professor Dr. Retnagowri Rajendram. Her topic is the updates on diagnosis and prognosis of renal cell carcinoma. Associate Professor Dr. Retnagowri Rajendram from the Faculty of Medicine, University of Malaya, is a pioneer academic scientist among surgeons in Malaysia, establishing their first laboratory, and she is also a PhD holder from the University of Queensland, Australia since age 25, with active collaboration as the Honorary Associate Professor. She's an advocate for cancer research, including renal and colorectal cancers, in form of publication and awareness campaigns, including among the Orang Asli community. She has achieved several international and national awards from private and public institutions. Example of which in 2017, the UQ Alumni Young Distinguished Award, and 2018, the Malaysian Australian Alumni Awards, and the Excellence Award in 2019 and 2022. Associate Professor Dr. Retnagowri was part of the steering committee for the National Medical Postgraduate Training, the directors and trainers for Malaysia between 2020 and 2024. She's also involved in educating science-based postgraduates, Malaysia urologists, cardiothoracic surgeons, and oncologists. Without further ado, Prof. Dr. Retnagowri.
Okay, so it's working. Can you all hear me? Alright, I assume like people move. Yes. Alright, thank you so much. I am between this and morning tea, but I really enjoyed the two talks before mine, and mine is actually focused more on kidney cancer, which is considered a smaller, less serious cancer for some reason, but having said that, it actually is the 13th most common cancer in Malaysia, and the incidents are actually increasing. And if you see, kidney cancer worldwide may be only 4.2%, but with the diagnosis rate, normally incidental findings due to scans and so forth, because symptoms only with a lot of other cancers, it ends up being quite, it takes a back seat. But what happens is when it's not diagnosed early, the metastatic form of kidney cancers, you have at least only about 6 months, or it's rarely a 5-year survival rate, especially when the kidney cancer is aggressive. So what are the risk factors? I suppose I wanted to give a bit of background of all of these things because I know the audience wide, there's not really kidney cancers, and I can't assume that everyone knows about it, so it was quite important, and also it links to the work which we've been doing recently in terms of obesity-related biomarkers. So I wanted to show this particular slide where it actually gives you the risk factors, which again, some of this would overlay with all the other cancers as well, but in kidney cancers, these are the main ones which are looked at in terms of age, obviously 50 and more, followed by if you have carcinogens, especially smoking, and it's found that when you obviously stop smoking, it doesn't promote cancer. In terms of other medical conditions, the main one which I want to show here is chronic kidney disease. So if you have kidney cancer, then you're more chances of having chronic kidney disease later. And why I'm highlighting this is because as much as we show the burden of kidney cancer being 4.2%, in terms of nationwide chronic kidney disease with having diabetes and so forth, then it becomes a bigger burden when people go for dialysis and kidney transplant and so forth. So actually it is more serious than just what is shown. Now as I was highlighting, so men are a little bit more at risk compared to females, but it's a small percentage. But the main thing is obviously, that obesity drives a lot of the cancers, and it does so for kidney cancer, and hence it's a serious thing. And our group obviously have been focusing a little bit on the adipokines, which I'll show you in much later. I've already highlighted this. So why am I bringing this up in a conference in nature? So it is the 13th most common cancer of all these cancers which are out there. So what is actually the way currently which they diagnose for kidney cancer? Similar to other cancers, they will use imaging, biopsy, blood, and in terms of regular screening, so it's not done, unlike for prostate where you have PSA, and for colorectal cancer, there is the FOBT kit. It is, as you saw, the percentage is at 4.2, so it's not serious enough where it's recommended screening because it's not beneficial in terms of cost effectiveness. But there is the high, so that's why I brought the risk factors in. So if there's family history or like your high risk groups, then maybe that monitoring and those people are screened. Otherwise, that's more actually of a follow-up and monitoring rather than screening. So screening normally happens when it is among asymptomatic population, right? So with imaging, the more common one is ultrasound and CT scans. But having said that, I'm going to move along to the next slide to show you the pros and cons of the current diagnostic methods which are out there and why we are still in the venture of trying to look at more non-invasive methods in detecting kidney cancer, whether it's early or also later in terms of prognosis. So in terms of ultrasound, so yes, it's non-invasive, there's no radiation, but then it's maybe not as accurate when it comes to smaller or complex tumors in terms of kidney cancer. So it's not always the best way forward, but it's used. And in terms of CT scan, there's radiation exposure. In terms of MRI, it's expensive and maybe not always available, as in the previous speaker has brought up, that the issue is that sometimes in certain hospitals and such, you're not going to be able to offer this. I'll come back to the red box, which is I'll finish off with biopsy and PET scan first. So in terms of biopsy, it is invasive. You could have bleeding, and sometimes it's not even if the images are sufficient enough for the doctors to decide, especially the surgeons, to decide to operate and take out the tumor. In terms of PET scans, again, it is useful in terms of when you want to look at the whole overall image and see whether there is the disease has spread and so forth, but again, it is pretty expensive, right? Now, coming to the two, where the biomarker sits, and in a way, biomarkers will align if you take the tissue out pathologies, we don't use biomarkers. So we would want urine markers because it's the most least invasive, because in blood, you will have to, people don't like giving blood all the time. But having said that, they have their issues, as I've highlighted here. But our group is trying to see if, so liquid biopsy, in terms of liquid biopsy, going to cover a little bit of some of this in terms of looking at epigenetics that will fall under circulating humans and DNAs and so forth. But it actually is broader than just looking at proteins and so forth. You can look at DNA, you can look at RNA and so forth in fluids, and the fluids is beyond just blood and urine. It can even be stool. Okay, so moving along. Now a little bit of our work. So how did I start off doing kidney cancer? So it was brought up by the our chair that's now in terms of my PhD project. Actually started off with this one published paper where I looked at RNA, microRNA, 120 genes, of which this was focusing on apoptosis. So in the hallmark of cancers, we know that one of it is evading apoptosis. So the focus of my project was looking at apoptosis because that was shown to be one of the drivers in kidney cancer. And from that, we identified some families of genes. So we brought it along and I looked at TRAF1, which is part of the ones which were highlighted in my original study during my PhD. And we brought it along to patient samples back in Australia, and then later we actually brought it and looked at it also in Malaysia and so forth in patients. And we did the functional work. I also, and my student looking at it in ELISA work in terms of blood samples. same student ventured into the same method as me, looking at other genes, and one of the things which was looked at is tumor-promoting inflammation again. That is one of the other hallmarks, and to see if there is any markers. The idea of us looking at just several of these different proteins expression was because we were hoping to move forward with a panel like which they have done actually with bladder cancer, where they have the CX bladder where they actually just need urine. So are we there yet? No, we'll see towards the end, but we're hoping we'll get there. All right. So I'm just going to spin through. These are all the different published work between myself and various students and collaborators. And we have looked at, these are all related obviously with apoptosis and steroid hormones and so forth, and the cost. And we did find that, so these are work which was carried on from my PhD, looking at the individual families which we identified in the very first paper that we wrote, and what has happened in terms of whether it is going to be useful or not. And we found that some of it are down-regulated, and probably that means it's not going to be, it's decreased in expression, so it's not going to be a best indicator, but it may be useful for like targets and so forth, rather than for diagnosis. But moving forward, a student over here, but also in a team, student who decided to do a master's, also looked at doing systematic review. So this was because we wanted to see, rather than just us using up samples and studying the protein expressions in samples, we wanted to actually maybe do systematic reviews because a lot of people are doing the same thing. And what would happen is, and hence that's what we ended up doing. We did a series of systematic and meta-analysis reviews. Besides doing our own work, we also looked at what other people have done to see whether it has value and so forth. Going forward, remember, one of the risk factors which I highlighted was obesity, and so we started focusing on work in terms of obesity-related adipokines, starting off with leptin. So this is one of my student work as well, where she looked at leptin and its receptor in human samples, in tissue samples and in blood and urine. And Christina looked at a systematic review of adipokines and found that it is actually going to hold some potential. And my other PhD student who is wrapping up, well, she should be wrapping up, ended up doing one of the other balanced adipokines which were out there. The reason is so that we can actually see which one should be driving forward in part of a panel. So that was all work which was done among my students. This was one which was done, well, led by me, but I actually was able to get an intern from A-levels who helped with some of the paperwork. But here was, this brings back to the very first image I showed you, because I was thinking, if we just keep going and selecting markers and looking at it at a very slow pace, we're not going to get there. So we decided that how can we look at diagnosis and prognosis faster. So we looked at a whole bunch of people who published around the world in terms of liquid biopsy, besides our own work. And what we found from that work is that there's still more work needs to be done, but there were some positive things where there is going to be value, because we did find that maybe a better way forward, not more than proteins, we found that actually the CF, DNAs, and so forth, circulating RNAs would be more useful in terms of diagnosis, in terms of prognosis, so maybe I will work with them more. And in terms of prognostic markers, similarly we found a similar pattern as well. So there is some value in protein in terms of prognosis compared to diagnosis and so forth. Okay, so moving forward, something which is up and coming is actually looking at vector in the gut microbiome, and that is very less studied, and that's probably a direction which we might be looking at in the future. But across the board, for liquid biopsies, more standardized protocol is required. Another field which is up and coming, and this is done by researchers around the world, is looking at using the CT scans and MRI and so forth. So they are actually using that to study images and see if they can improve that. AI can help in assist in terms of diagnosing for cancer biology, and also using it in terms of looking at detecting, in terms of detecting histology images as well, so that it's automated. And they use something called deep learning. So I thought this would be useful, especially for people who don't come, including myself, so much from AI background, but is that artificial intelligence is broad, and then machine learning is an arm of it, and actually deep learning is a very specific arm which looks at image. So if you have like, you do the next slide. So if you actually look, you might have images, so it could be H&E slides, it could be images, it could be even be genetic work, and it can actually study and see patterns. And in this case, it's basically if you have a grid going from A to G and 1 to 6, and you want to look at a specific point and ask it to focus and study and so forth. That's how deep learning works. So more than that, you need to ask computer scientists. Okay, now what are the challenges we're going to face with all of this? So I did bring some challenges already in terms of imaging. Besides the cost and radiation and so forth would be issues. Okay, and obviously it's not always specific in terms of knowing the size and so forth. In terms of signs and symptoms, across all other cancers would have similar symptoms, and the one which is shown to be more unique for RCC per se is also not that high of a percentage. So it is not going to be something which you can focus on looking at just signs and symptoms. And in terms of screening, it's not recommended, and this is by the EAU guidelines, where they don't recommend it because it's not not for primary screening at least, but more for, as I said, in terms of risk stratification. So screening is probably not the way to go. But if you look at, so I've already highlighted biopsy is at risk, but this is what is used. It's not really used as much anyway because the imaging is enough. But this is for diagnosis, but in terms of prognosis, maybe they might continue doing some biopsies and so forth. Now histology, it is useful, but okay, so it is useful, but what happens is immunohistochemistry strains which are recommended to confirm things are not as sufficient at the moment. And so more work probably needs to be done in terms of looking at better markers at the tissue level, especially if you want to see if patients are going to be sensitive to the therapy or not. And liquid biopsy I've already highlighted, but the problem is now we need to control the environment, biology, physiological factors, and so forth, and then we need to adjust in terms of urine, as much as we want the urine dipstick test, because that is the least invasive way to go, we need to then try and factor in making it sensitive and more specific and so forth. And so this is probably the areas in which should be worked on, the final three, like including the histology, maybe using AI to help the histology and so forth. Okay, so challenges with artificial intelligence is that obviously you need computer scientists and experts, you need to train the model and so forth. And in terms of maybe socio-economic issues and data privacy would all need to be addressed first going forward. So in summary, we probably want to go with a more integrated way of bringing liquid biopsy with biomarker research and AI-driven in order to actually help solve the issues we are facing in terms of particular diagnosis, in terms of also later something in terms of prognosis. If you want to give treatment for patients, you probably want to give treatment to a patient who's actually going to be more going to actually respond to a treatment better compared to just giving a treatment just because that's what the guidelines say, so more like patient-centered care. Thank you. So I do want to go through this. So it's starting off from the left is actually my PhD project. Among this group are senior pathologists, urologists, anatomists, my students who did their master's or their PhD. Christina, who's in that top photo with Prof. Jaya. I don't think I am pressing anything. So over here, Christina did a lot of the initial work which I showed you with the track one and so forth. Prof. Mine is also a pathologist and he's an oncologist. and over in UK and here in Malaysia. So she's the one which did the liquid biopsy people.